welcome to another episode in the series Idea Collider, which is a series on innovation and some of my favorite people within the space. And I'm delighted to welcome Peter Bach to the to the podcast as someone who I think I first met on Twitter, or was first exposed to on Twitter. Because he's one of the more authentic voices out there, and clearly occasionally antagonistic to the pharmaceutical industry, which I found appealing enough to want to get to know Peter a lot more. So Peter, welcome to Idea Collider.
Thanks so much for having me, Mike.
And thanks for agreeing to do this. I'd love, for those who don't know you from that world, tell us something about you and how you got to where you are.
Yeah, well, the short version of the story is I'm a doc. I'm a pulmonary and critical care physician, and in the course of my training and in the course of taking care of patients, became gradually more and more interested and concerned about weaknesses in policy, particularly in the U.S., that were impeding access to the highest quality care and therefore the best clinical outcomes for many people. And there's legion reasons for that: care quality variations, high costs, limited insurance reach, undesirable or problematic insurance benefit designs. And so I pursued additional training in public policy. I took a break from my clinical and research job at Memorial Sloan Kettering, where I run a research group, to work for Medicare. I was Mark McClellan Senior Advisor in 0506 at CMS, and became increasingly interested in trying to use some of my time to help first identify some of the challenges in public policy and healthcare in the US, and then try and fix them with evidence-based solutions. I have, over the years, become increasingly focused on pharmaceuticals, because it is the only area in healthcare where we do nothing at all about pricing. In the other major areas of spending, we have become comfortable with negotiated prices, rate tables, and other sorts of interventions that at least somewhat manage spending, although poorly. And so pharmaceuticals are the place where, if you will, the last frontier of rational policy. And they're also, during the course of my career, the most exciting scientifically. And so it is the place where the potential improvements in health versus the gaps in access have the most profound impact. And so I think it's an important area to work.
Yeah, and it's do you feel that everyone sees the same problem that you do in that world?
Oh, I don't think there's any question. People understand that there's a massive gap between access to pharmaceuticals in the US that could help people and the potential health gains they could deliver if access were improved. There are alternative narratives explaining that, one of which I think is just plain illogical, is that the defect is purely due to insurance benefit design, that if we just, made drugs more accessible by covering the full cost of them, for example, through insurance, then we would not see those gaps. The problem, of course, there is if we do nothing about prices, we've removed the one inefficient and problematic, but still the one check on pricing, which is the ability of intermediaries to use co-insurance and co-payments to try and either reduce utilization and therefore spending, or get price concessions.
Yeah, and as you know, we have Peter Kolczynski on here in his, targeting especially the insurance system as a significant part of the problem. How would you describe the kind of problems at a kind of macro level?
Yeah, I didn't hear Peter's podcast, but it's not uncommon for investors in the pharmaceutical industry to bemoan a competitive market for insurance where there's transparency on benefit design and its relationship to premium as somehow a bad thing, but monopolistic pricing by the pharmaceutical industry is a good thing. And that seems to run counter to any theory of markets that I'm aware of. But there's no question in my mind we've ended up in a very unfortunate balance. Prices are high access is poor because the response to prices has been to impose coinsurance and copayments. And remember, that is not just used to get price concessions, it's also done for the very point of reducing utilization, because that reduces expenditures. We would be better off if prices could be lower. In exchange, co-insurance or co-payments could be trivial or non-existent, and pharmaceutical companies could get the same revenue and the same profits, if you will, by having a larger volume of sales at a lower price point. But our current market doesn't support that kind of solution. Instead, we have limits in access, we have kind of cascading price discrimination, we have lots of patients who could be made better off by access to therapies that they're not getting, whether it's Gleevec for cancer or Sovaldi for hepatitis C.
Hmm. And Sovaldi, I know, raised that sort of issue a few years back about, what's it worth, and then introduced that. Well, what are you comparing it to as a source of value? We're almost seeing the contrast of that with the COVID vaccines, where people are speculating about the potential cost of a vaccine to produce and therefore distribute, without looking at its value to the individual. So, where do you feel like we're moving in terms of, what is the industry going to want to move towards? What does government want to move towards? What do insurance companies want to try and protect?
Yeah, the one, for sure, one of the challenges is that each of the players in the industry is in their own way benefiting off of the current problems in it. The intermediaries actually benefit from the fact that there's kind of unprecedented price discrimination. Every contract can be negotiated separately. All of them can be confidential. The scale these entities like the PBMs use don't lead to efficient pricing. They actually just allow the intermediary to gobble up more of the surplus. And the pharmaceutical industry is sort of forced to choose between the devil it knows, which is the current one, and an alternative regimen that I think, which would, for example, be health technology based or incentive based pricing or something like that, which I think they rightly fear could look good on paper, could be good out of the box, but once you hand regulators the reins, it could lead to gradual downward pressure on prices when anyone wants something new, whether it's build new bridges or expand Medicare to include dental coverage. They'll look to drugs as a place to get what people call a pay for, the savings that you could put into legislation to pay for something else you desire. So, but on this value question, so Sovaldi, or obviously there's newer products now. The pharmaceutical industry would embrace value pricing because it in and of itself is not a desirable way to price drugs, except from their perspective. It makes very little sense to say we should pay for Sovaldi what it's worth. The only place value and value assessment or health technology assessment or dollars per quality should come in is as a ceiling for the price above which we should not pay, because it's less good use of money than something else like building bridges or educating kids or paying for basic preventive care. So even the notion that somehow, Gilead in this case should have been paid based on the health returns of Sovaldi is a misunderstanding of how incentives work. What you want to do is pay Gilead or any of these other companies the bare minimum you need to so that they will engage in the innovation that you want for society. And that, of course, is how all markets are supposed to work. That's how competition moves the surplus or benefit or added value of the new technology to the people who receive it rather than the people who make it. And it is why monopolies are bad, because they keep all of that surplus or added value. So, sorry, do we need to re-record that glimpse of?
Okay. I'll clip that bit out. Yeah.
Okay, sorry. But anyway, hold on one second. Mike, hold on one second. Sorry, are you there? Can you
I'm
hear me
here.
again?
Yeah, yeah. It
Okay,
also
great.
coincided with a period of barking here.
Well, that was our um,
Some mad 2 minutes. Yeah.
perfect. Okay, I recognize that doggy. All right, so um, okay, so we can go. Let's drop that wherever you want to start. Do you want to go back to a question, or do you want me to give that answer again?
Let's do that answer again, because you were going really nicely into the kind of that question of, yeah, I like that one.
Yeah, okay. So, with regard to, I'll just talk about value in a second. With regard to value and whether or not, for example, for Sovaldi, the right price of it was anchored to the value it created for society or the savings for society, that kind of thinking is very desirable for the pharmaceutical industry because it's somewhat wrong-headed, because it suggests that the proper incentives for innovation are transferring the full value of any innovation to the company. Actually, the price we get from a value assessment tells us what the ceiling should be. We should pay no more than the value for sure, because we could do other things with money, like, I don't know, build roads or educate children or help people manage their diabetes or lose weight or have better nutrition. So when prices exceed the value threshold, they're unreasonable. But the price we should be trying to pay is that one that uh, adequately incentivizes the innovation, and we should pay no more than that. And that is what competitive markets do. They create rewards where the price in the market transfers the least amount of excess surplus to the maker of the product and leaves most of the value with the consumer. And the problem with monopolies is monopolists grab all of that excess value. And in the US, at least, there's a lot of evidence that no matter what threshold you have for how much you think, I don't know, you should pay for a quality or something like that, a quality adjusted life year, many of these products were paying vastly in excess of that. During a monopoly period that the manufacturers have become very gifted at extending through blocking competitors, through patent extensions, through locking up channels. And even when there's brand competition, we don't really see in most markets much of a reduction in prices. So it's, I think, vitally important we consider alternative ways of finding those prices that will drive or incent or pull the innovation forward without anchoring them to value. Like I said, that should be a check in the system. It's
Yeah.
why I like auctions. It's why I liked, the Netflix approach as ways of getting the companies to signal what the prices are that they would need. And it's why, Mark Trusheim and I called for an auction for COVID vaccines.
Mm-hmm. Yeah. And there are 130 people lining up to provide them, right? So it's an interesting, I think, test case for our industry. So I want to come back to the Netflix idea, because your piece on that. So last year, everything feels like 5 years ago now.
No idea.
But,
in COVID years, who knows?
Yeah, BC.
Exactly.
So clearly the US is an outlier in many respects, because of that system. Do you feel like any nation, any country has this figured out, or provides a model for us to aspire to in the US market?
I think there's quite a bit to learn from a number of countries. We're going to need our own unique American solution to this challenge, which will probably have to begin with acknowledging that we have a problem. I think even if you think money is somewhat infinite, I guess you can't modify infinite, but even if you believe money isn't a constraint, lack of access is a problem. The gains we should be having compared to the gains we are having are a product of it. I admire the British system to the extent that there's a formal process for figuring out thresholds. I think NICE and health technology assessment out in the open in that way has great utility. As I mentioned, I think they've used it sagely in terms of setting price ceilings for certain products. I think the thresholds they use are probably too low for the American appetite, although we've never had a formal process in the US for figuring that out. We've just sort of digested, I think, largely industry sponsored health economists saying that our threshold should be, 3 times that, 5 times that,
Yeah.
and the rest of it. Uh, we do, of course, in our government, do allocation decisions based on health gains, but we don't do them in healthcare, ironically. I think the German system has a number of features that are attractive, including a lot of emphasis not on health technology, but on comparative effectiveness, which is, if you will, a first cousin to health technology, to cost effectiveness, in the sense that new products kind of get their chance, but if they can't prove better than existing products, they get crammed down on price. This ICWIG model, if you will, I think has a lot of merit, because one of the challenges we have here is that the metric for success in the pharmaceutical industry has become binary. It's new drugs getting approved. The measure of the FDA has become how many drugs can it approve. And that suggests that a reasonable way of measuring innovation is to just count up new drugs or new indications, if you will. And that seems pretty lame compared to the complexity and heterogeneity of what drugs do. There are new drugs that get approved that are not meaningfully better than existing products, simply more expensive. And I could list a number. There are new drugs that get approved with essentially no evidence that they work at all. There's new drugs that are approved, like the Hep C treatments, which are potentially transformational, or the immunotherapies. And I think it's a mistake to view them all through a similar lens of this new drug got approved, and that represents an equal increment of scientific progress. One of the consequences is, as I mentioned, this metric of new approvals. And if you looked at the scoring of the Pelosi bill on drug price negotiation, the furthest the Congressional Budget Office was willing to go was, this is the number of new drugs approvals that will not happen because of this. And it was a very slight effect. It was like approval rate stayed at whatever, 97, 98% of current. But nevertheless, the question you want to ask is, does that mean we don't get a Hep C treatment, which we should care about? Or does it mean we don't get another treatment for spinal muscular atrophy in what's already turning into a crowded market? Both of them would matter from a health perspective, but would differ by orders of magnitude in their public health importance. So I think that kind of thinking is a really important place to begin. That we want to be asking ourselves, is this market? Is the type of innovation that's coming along? Are the prices we're paying? Is that really what we want for drug innovation? And to that point, I've been trying to emphasize over the last few years that policymakers need to realize they own this entire ecosystem. They have invented it, and they regulate or fail to regulate by choice every element of it. Drug monopolies are protected through laws that policymakers created, whether it's FDA exclusivities or if it's entry on the market, such as FDA standards for approval. The durations of exclusivities, what kind of patents are in place, which kinds of drugs are favored by Medicare to the point that Medicare can't have formularies, which drugs must Medicare pay based on market prices and which ones not, what are the markups for different kinds of prescribing that incentivize one use or another, what in Part D incentivizes high-priced drugs that kick in with reinsurance and which ones don't. These are all policymaker choices. Even the choice to have invisible pricing is a choice. The Medicaid drug rebate program could easily be done with transparent reporting of prices. Part D plans could have transparent prices. These are choices policymakers have made largely because I believe the pharmaceutical industry sees them as preferenced, or sees prefers these choices
Hmm.
rather than it being necessarily sensible policy.
Hmm. Yeah, there's this kind of, there is a suitable fog of kind of opacity to how and why they made the decisions that they made. And I
Yeah. It doesn't make sense. I mean, the argument with for confidential prices has something to do with concrete sales in Denmark in the 1970s. And, the apparent finding that secret prices allowed everyone to save more money than if prices had been transparent. Um, the fact that the pharmaceutical industry is the strongest proponent of confidential prices suggests to me that they know something we don't.
Hmm.
That if it were actually yielding lower prices and revenues to them to have them be confidential, which is what, of course, they claim, then they would find it undesirable and seek to have prices disclosed. So it's rare for firms to speak against their interest. It's common for firms to falsely claim what they're pushing for is against their interest.
Hmm. And certainly pharma as a lobbyist pushes hard at the idea that it's the middlemen who are, creating this situation, and we're holding our hands up and wishing it wasn't so. But, what can you do when you've got, so many people with their hands out on the way through? Do you feel that's obfuscation, or, is there any truth to that idea?
Oh no, that's clearly one where they're right, but that the middlemen have become oligopolists and are misbehaving, but they skip that class where they learn the definition of the word irony, because it's the monopolists complaining about the oligopolists extracting some of their rent. I get it. It's pretty easy to paint, for example, PBMs as not adding much value. But the reality is, and we saw it with the rebate rule, that if you eliminated what they do, which I think they do inefficiently and not in the interest of patients, but still, if you eliminated what they do, total spending would rise because prices would rise. This is not a good system, but it is the seesaw, the counterbalance that we have sort of settled on.
Hmm.
I would like to see the PBM market broken up and have actual competition between PBMs based on things that the people who pay them, whether large employers, the Medicare plans, are actually purchasing things based on dimensions that we should all care about: total spending, co-insurance, and out-of-pocket costs, access to preferred formularies that are actually based on the therapeutic benefits of the drugs in them rather than whatever price concessions are in place, that rapidly move to introducing generics and biosimilars when there are some. That market is not great anyway. But now that it's an oligopoly, there's no question these intermediaries have figured out whose priorities they're going to focus on.
Mm. And so, do you have a kind of working definition of innovation? Because I think that clearly that piece is the piece that we keep pushing back. The industry keeps pushing back on and say, well, if you want innovation, you're going to have to pay. So, do you have a definition that you use?
I mean, it's an unfortunate term. The root of it is simply new, and I think that we certainly want academics, the National Institutes of Health, private firms, small and large, to be seeking new treatments for people. And I'm a couple decades in now. I've seen astounding, fantastic things come out of all of those places, and that have been to the benefit of patients. But as I mentioned earlier, I think it is a mistake to assume just any new drug is an innovation. Just looking at COVID, of the therapies we have, the vastly more important one for severe COVID has been dexamethasone, a steroid that I want to say came on the market in the 40s or the 50s, super cheap, clear evidence of a mortality benefit in patients in hospitals. And then we have remdesivir, which is the innovation. It's still not approved for marketing, right? It's just under emergency authorization in the US. It's certainly newer, but the data on it are far less impressive. Never mind that there's production distribution problems. So, I think that's a pretty good foil for this challenge we have, that newness is mistaken for health value. And more important, the signal to the market is, I don't know, if there's any incentive out there for dexamethasone anymore. But the signal to the market is, if you can pick your price for the drug, and as you know, Gilead sort of reverse engineered a price based on length of stay benefit for remdesivir, which is entirely unsupportable based on empiric data. And then went public saying they were going to give discounts to government programs, and what they meant was basically the Coast Guard and a couple of other small programs with Medicare, Medicaid. They're, and the hospitals that are financed by them aren't getting a penny off. So we're paying, much more than any other country for the product. But nevertheless, if we allow this sort of free market and kind of baseless framing of rationales for pricing in the market, we're sending signals to the company that new is what they should create, not health. And I know it's harder to signal on health, but it is the very purpose of health technology assessment to make those signals align better.
Yeah, and it is a very remdesivir is a really interesting case study for avoided hospital days becoming the price of a therapy, right? I mean, it hasn't been used before. In my experience, to justify such a high cost for
it's in a lot. The cost saving, well, two things, right? One is the avoidable length of stay coming out of this trial, ACTT1, is entirely implausible. The trial only enrolled people who looked like they were going to have a long length of stay. It excluded people who were expected to stay less than 72 hours. By doing that, they artificially elevated the median length of stay in what was a control group to about 15 days. Data coming out of Colombia that we've published now is that the median length of stay without remdesivir is about 7. The duration of treatment for remdesivir is 5 days. It's an inpatient drug. And their own data from Gilead suggests that in an open label trial where patients had to get 5 days of remdesivir, they were getting held to receive it rather than being discharged. And you can see it was just published, I think, last week, this very nice example, if you will, of doctors preferencing holding patients to complete the remdesivir, because then there's this big bump, which there isn't in the control arm. Wow. So it isn't a defect of the ACTT trial, it's a defect of its interpretation that remdesivir would reduce length of stay by 4 days. Never mind that actually wasn't even the outcome as originally designed, and it's actually not even the outcome that was measured in the post or in the mid-trial outcome change. So there's lots of reasons to think that's overblown, but there's lots of other examples where drug companies have used avoided costs to justify their therapies. For example, Novartis justified the cost of Zolgensma, the gene therapy for SMA, by comparing it to the cost of Biogen's Spinraza. And so what they really did was bake in an absurd price for some other therapy into their own, because the analyses of Spinraza's benefit relative to its price suggest it is wildly overpriced. I think the proper price is supposed to be something like 20% to reach 150,000 per quality threshold. So that's a classic example of a company saying, and this is what BioMarin was kind of up to when we expected their hemophilia therapy to get approved. They were comparing it to factor VIII replacement costs in the US, leaving out that the US overpays for factor VIII compared to any other country, that some of the factor VIII replacements should have biosimilar competition and should have long ago, but don't. That, we just sort of, all the defects of our pricing system then got internalized in their own analyses. And they said, look, we're going to prevent you overspending on these other things. So overspend, if you will, on our product.
Yeah. And, the other argument that is thrown at skeptics is the one of, well, we need to pay for innovation somehow. We need to, and the winners need to pay for the failures, ignoring that a good 50% of the failures in late stage are actually business decisions. They're not, efficacy or safety failures. Do we feel like that kind of perverse incentive structure within the US is leading to us, overpaying pharmaceutical companies for their efforts within the kind of R&D and commercial environment?
It's difficult to paint them with a broad brush. I think that some of the companies really are spending most of their research dollars on trying to invent new therapies. But let's face it, most of the big pharma companies spend nearly all their research money, probably 80 cents on the dollar, on franchise extensions, either marketing trials or efforts to expand labels, rather than on testing new ideas. And then they purchase companies, and you could argue that that's a version of a research expense, purchase, in multiple different ways, as we both know, new products from smaller companies. But this is one of the simplifications that works for a narrative, but doesn't work in real life, that the pharmaceutical industry's money on research is about innovation. It's about several things, one of which is testing new ideas that are high risk. But a lot of it is just about, doubling down on the things that are producing revenue. And in some cases, of course, ironically, a lot of that money goes to lawyers to extend patents and block competitors, which is, I guess, a good employment deal for attorneys, but I think pretty far afield from what we think of with innovation as as an objective. But it's, if you think about it too hard, this notion that we should be paying for failures suggests a correlation that prices should be higher when there's more failure. Now, if that's true, you could argue one of two things, right? One is you could say, well, at the company level, that sounds insane, right? Like we should basically be paying higher prices for the products of the companies that are worse at bringing products to the market. That sounds like, incentives for the stragglers. But you could say, okay, fine, that makes sense in one scenario. So to just use a baseball analogy here, we actually want these companies swinging for the fences, right? We want them to go up and just take a hard swing at every single pitch, which means more strikeouts, right? More men, not getting to first base. And that might be okay. And you can certainly look at some baseball players' salaries and argue that lower batting averages and more runs batted in is a preference, or more home runs or something like that. And so you could look at that and say, well, actually, the failure rate at some level is a reflection of swinging for the fences. Great. That's what we want. We've got enough singles, kind of thing. The problem is the evidence doesn't support that, right? What the evidence supports is that although we can, of course, salute some of the great innovations and progress that have happened, the average improvements in outcome, let's say in oncology or something like that, are highly variable and not consistently rising. The average improvements in many diseases are non-existent, like diabetes, this sort of endemic damaging condition that takes people out of work and causes massive reductions in life expectancy. And so if you could show me that failure rates are rising, or if you will, the cost of success is rising, but more of those successes are clearing the fences as opposed to being dribbling singles up the middle, you'd have an argument. But all the analyses suggest it's quite the opposite. And some of the most celebrated therapies that come on with very high prices are actually pretty unconvincing in terms of their data. And so we have this other interaction where the FDA's standards for getting products on the market is also shifting over time.
Yeah, and almost clearing a safety hurdle instead of clearing an efficacy one, which leads to kind of a related point. Do you think that we measure effectiveness or efficacy of new drugs very well? Because I think some of the challenge with qualities and other things is that we apply old metrics to new drugs, and things like PFS-OS are very hard endpoints in diseases where other things matter. And I remember, an RA marketer just saying, well, how would you know if an RA therapy had worked? Which was a very interesting question. And the idea that a drug has worked and is worth paying for because it's worked, he was pushing back against that idea that you get paid for performance. Oh, got some thunder here. That you might get paid for performance was anathema to him because he couldn't define what an RA drug working would look like. Do you think we've got the right metrics in place for innovations?
Yeah, look, it's one of those things. I want to be cautious with my answer because, actually, forget it. I don't need to be cautious with my answer. All of these measures should be things that we constantly could reconsider. Measurement, whether it's measuring effectiveness or safety, should evolve. And if the FDA can have a bar for effectiveness better not from a scientific perspective be binary, which means it's continuous, if you will, or
right.
monotonic or something like that. And so if there is a metric, we should be able to anchor it to something else. We should be able to quantify. It's, one of the reasons I built that drug abacus so many years ago was that I was hearing from people in the pharma sector, well, of course we'd like to measure value of our products. The problem is we can't. There's too many dimensions. And I took that on as a challenge, that, wait a second, name a metric. I can operationalize this thing. I mean, it won't be perfect, but it'll be certainly better than just pretending we can't. And, it could be refined over time. We could measure the things that we decide matter. But it's a product evolution, but it's sort of nonsense on the other side, if you will, people saying, well, qualities aren't fit for purpose, so we shouldn't do anything. We should just let companies set whatever price they want, because somehow we can live in this cognitive dissonance where the companies are charging a price that reflects the value of the therapy, but there's absolutely no way to measure the value of the therapy. And that, those two things cannot coexist and both be true.
Yeah.
So to your earlier point, I mean, you mentioned something about the FDA, and so did I. I would be completely comfortable with a world where we allowed drugs on the market when their evidence of effectiveness kind of tipped the scales as the glass being half full. If we then had pricing that reflected that, and we had a clear path for companies saying, well, no, this glass isn't half full. Here's another trial. This glass is 90% full. We get a new price. I would be perfectly fine with a dynamic tiered approval process, which we kind of have with accelerated approval and confirmatory full approval, and a dynamic pricing environment. But I'm not comfortable with this sort of cognitive dissonance. So, on one hand, we have Luxturna, right? A gene therapy that improves sight, amazing piece of technology. Another side, we have Blenrep, a drug for multiple myeloma that causes blindness. And somehow Luxturna's value for improving sight is hundreds and hundreds of thousands of dollars. But Blenrep, which has only partial response data in myeloma and causes blindness, is also worth hundreds of thousands of dollars. And those two things, again, cannot coexist and both be true. And we can't have a system where every drug gets its own scale, because this is society's money, first of all. But even if you ignore even if you make a reasonable argument like, look, this is on the margin trivial spending, so let's not freak out about spending on drugs. It's only 14% healthcare. Let's focus on other things like physician rents or something like that. But even if you do that, you still want the incentives aligned. You want to send signals to this innovation ecosystem, which keeps telling us you need to pay us to innovate. Well, then if that's true, we need to be smart about how we pay you so that the innovation meets the society's goals, because it's the money from society that's incentivizing in the first place. So we cannot have a system that says blindness and alleviating blindness is worth nearly $1 million, and causing blindness with only a partial response from a therapy is also worth $1 million to the company. Or in this case, I think it's about $300,000 a year for Blenrep.
No, I hadn't thought about it that way. It's a very interesting tension and lack of logic within the system. Um, I want to give room because I think the Netflix type idea, I think one of the things I've written a lot about is why we're not seeing innovation in the commercial environment in our industry, rather than just in the research and development world. We haven't tried a lot of new ways of doing this. So, could you tell me more about the Netflix idea for pharma?
Sure, be happy to. So it emerged, and full credit to Mark Trusheim at MIT, my colleague. It emerged based on what we thought was a convergence of phenomena which are unusual. The idea, as I mentioned earlier, is that most pharmaceutical companies maximize profits by charging not only high prices, but price discriminating aggressively between payers. And in the Hep C market, what we saw was very low penetration into the population was the profit maximizing strategy for the companies, Gilead up front, but then later other firms. And we did, of course, see price declines with competition. But there's certain things that are special about Hep C, right? One is that it's sort of a one-time problem. If we treat everybody, it's only essentially human-to-human transmission. So if we can kind of get rid of it, we're good, we're done. Another was that in many areas like oncology, you wouldn't want to extinguish future innovation because we're kind of not there yet with, be it CAR Ts or immunotherapy, we're not there. Our view was by the time we had Harvoni and Maverat, we were done with innovation, that there were adequate products to take care of the problem or take care of 96% of the problem, and waiting for the last 4% wasn't productive. So you have this one-time problem and you have an adequate product for it, and you have competition in the market between meaningful players, in this case, Gilead, Merck, AbbVie, players that could step up and take financial risks of various kinds. And for that reason, we thought it would make a lot of sense to auction off a cure, auction off curing a population. Netflix as a concept comes from, an obvious analogy. You pay monthly for Netflix and you get as many videos as you can handle. And so we called it Netflix just so people could anchor on that idea that you would pay essentially a subscription to, be it Gilead or AbbVie or Merck, whoever wins the auction, and you would get an unlimited supply of the product. We benefit from the fact that pills are cheap to make and distribute. So we could sort of, in a academic sense, ignore the cost of production. So Gilead doesn't care at some level if it gives out 1,000 prescriptions or 10,000 prescriptions from a dollar's perspective. And so it was that confluence that sort of drove this idea that, maybe these states should put out a request for proposals or run an auction or ask for bids and say, like, look, here's the deal. We think it's going to take 5 years. We think your marketing engine is really terrific if you put it to good purpose and try and do outreach and screening and teach doctors to use your product so we can get rid of Hep C, and tell us how much it'll be. And we'll pay you a flat fee. You give us as much drug as you use. You kick in with us to eliminate this problem. At the end, there's a kicker payment. If we kind of collectively make these population health objectives, we will also pitch in to do those things. And, it's what's now happening in Louisiana and Washington. The early data out of Louisiana is that the uptake of Hep C treatments, jumped when they kicked in the Netflix model. Last data I saw was in March. They post it regularly. I'll have to look at where they are now, if they've posted again. There's a lot going on in Louisiana, obviously, right now.
Yeah.
But that isn't, we wrote about this as, a somewhat bespoke solution. It's difficult to see other examples where it would work well, although the COVID, it's why, Mark and I later analogized it to the COVID vaccine market. As if we had a vaccine that reached effectiveness that was sufficient for herd immunity, like 70% or something like that, and an adequate toxicity profile, this would be a similar environment where you could use an auction process to elicit the price that the firms, or the reward the firms would demand to develop and distribute this.
Yeah. No, I think it's a fascinating model. And certainly we worked on that idea with one company in oncology, with an oncology portfolio, the idea that you might offer payers a fixed price access to the kind of to the portfolio. And the interesting thing was payers actually said that we'll pay twice what you suggested, because actually our biggest issue isn't the price, it's the predictability of price. It's a bit like aviation fuel for the airline industry. And it was the company that didn't want to do it. And the reason was the CEO, I'll not name the company or the CEO, his quote was, "I am not going to be the person to break the pharmaceutical industry." That was the quote about why they wouldn't do this. But there was an advantage to everyone in access, in reach, in all of those things that you just described. But I do take that point. You want to see more innovation in this environment, right? We want people to be taking newer, better medicines. We should be looking for ways to do it.
No, and look, it's, I've tried to explain how the market was amenable to it, but you've mentioned some other things that are pretty important. One is that, from the firms, the drug companies' perspective, the predictability of future revenue for franchises, especially that were highly unstable, like Hep C, was attractive. We thought they would give the states a premium, if you will, or a discount in this case, for that predictability. The predictability of spend for the state is also useful, but it was one of those rare examples where everyone could be made better off. The state could improve health more. The company could have more surety of revenues. Plus, the companies are not soulless entities. They're full of people who care actually about their products reaching people. And so the non-monetary benefits to the company of actually doing things that improve public health more are non-trivial. So it was really, we thought it was an interesting confluence, and thrilled. There's more states now apparently looking at this idea. Absolutely thrilled it was taken up.
Yeah, sorry, quickly unmuted there. Yeah, absolutely. And I think it's one of the things that we have to solve going forwards, I think, for reputational issues and a lot of other things. I'm aware that I've eaten up a lot of the time that I had allocated, Peter. And I know that we won't cover everything today. I'm going to get into some other areas. So
Okay.
Before we close, I'm interested in places that you would recommend we go read, books that you'd recommend, things to watch or listen to.
Oh, you mean outside of drug pricing?
No, I mean, or in drug pricing. I think any reference text that you think we should all be getting hold of.
Oh, that's a good question, and it comes out of the blue. I'm going to have to think. I one of the challenges I think in this discussion is actually that the kind of general insights haven't been well consolidated. And so most of what I read are, journal articles and reviews of various topics, and they all sit in the ether separately. I was reading some articles in Science about patents and how they affected biosimilars. Read Health Affairs about, how formularies work in Part D and whether or not generics are actually being excluded in preference for brands or not. And so you end up with this smattering of knowledge, and it's difficult to find, I think, a comprehensive overview. I know my colleagues and I have tried to write a few of them, but boy, it's boiling the ocean at some level. So I don't mean to dodge the bullet on this question. I can tell you for my pleasure, I don't read about the healthcare industry. I prefer reading about literally anything else. And when books do come out or long form articles come out about the industry, I read them as work, not, not for enjoyment, just to see if, there's stuff I'm missing, if you will.
Yeah, no, I would tend to agree. You go looking for this stuff and say, well, where are the analogs, or the should we look at Hollywood as a model? Should we look at or the airline industry or the nuclear power industry, or what is it that we should be looking at as a way of fixing incentives and rewards?
I don't think there's a one industry solution, but I found it very useful. As I've mentioned before, I work with Mark Trusheim a lot, who came from the agricultural industry at first. And what's really useful, I think, is that some of the ideas, like our idea that we should price regulate biologics after loss of exclusivity, which, by the way, is built on the notion that the market for biosimilar entry is fundamentally flawed, not just a defect of kind of some policy missteps. It helps to work with people who know these other industries well and know that things like price regulation and price reporting have worked across many, I'm sorry, know that things like price regulation and price reporting have worked very, very well across many industries, that there's a lot of precedent for doing it. And that doesn't mean everything should look, for example, like agriculture or electrical utilities or nuclear power. But the fact that kind of the government and industry have successful track records of doing things that look like what you think would be attractive in a particular sector, I think is reassuring. And it also helps debunk insistence that, we've never done this, this won't work, everyone will cheat, things like that.
Or we won't get innovation on the other side. I think you look at the telecoms industry and the enforced sort of separation of monopolies there, and how much innovation happened afterwards. So I think,
yeah, I'm trying to figure out, Mike, how long it'll be before, when we say dial the telephone, people will literally have no idea what we're talking about. I'm pleased that we still use the term, but I actually asked my child this recently, and it's like Kleenex to him, just a word that has a specific meaning that has actually no origin at all.
Yeah, or like floppy disks on a save icon on Office, or
I didn't even think about that. That's right. It has the little, what is that, the 3.5-inch disc on there. That's right.
But I think somebody said that Terminator, the movie, the kind of the most unbelievable thing to kids these days is not that Arnold comes back from the future, but what it is, why he goes into a telephone box and then looks at this book where everyone's numbers is written down in a book. that idea to see, when was that?
Yes, well, my favorite version of that is the original Blade Runner, with Harrison Ford. They of course have flying cars, but when he has to make a phone call, he goes to a phone booth.
Right.
They got the pace of technological innovation wrong there. And, it's we do have a competitive market for automobiles, I think, but there's no question that the introduction of competition in many of these sectors has yielded a lot of fruit. It's why, as I mentioned earlier on, I'd really like to see the PBM industry broken up. I don't see a reason. The vertical integration, I think, has been very, very damaging. But I think more importantly, the vertical integration is a secondary effect of consolidation in the market. And it is industry that could do much more good, I think, rather than undermining it, which I understand the pharmaceutical sector would like to do. We should really see if we can get competition and get real products out there that would work better.
And we even know, as Gerald Posner pointed out in his podcast, the PBMs were started by pharmaceutical companies as ways of managing, their own distribution. So it's, I think we do have to, think harder about this. Peter, it's been a pleasure as always. How can people find you more easily online?
Yeah, so I am, as you mentioned, I'm on Twitter. I actually don't know what my handle is, but has my name in it, I believe. And then we actually have a lot of our work on drugpricinglab.org as well. Okay. We try to put everything we publish in the various formats in there, as well as track some other important developments. But there you can find the Drug Abacus, our real-time policy tracker in healthcare, the original Louisiana budget allocator system that we posted in order to encourage the state to consider alternative financing mechanisms, because we posted how much they would have to take from other programs to pay for Hep C treatments at their current prices, and then a bunch of other work we've done, ranging from journal articles to lay press publications.
Fantastic. I will make sure to include links in the show notes for all of that. It's been wonderful. Peter, thank you so much for your time, and stay safe.
You too, Mike. It's a real pleasure speaking with you, as always.
Thanks again.
Take care.
I'm focused on getting pharma to rethink the commercial environment, because there's just been no innovation there at all. So
they're in a difficult place. And, to your point about, Merck Medco, and I liked Posner's book, by the way. I think it's how they feel about price regulation too, that, they'd probably be fine with ICER doing price regulation in its current form.
Yeah.
But I think once you hand over the reins, if you look at what happened to physician payment once Medicare got a hold of it, or hospital payment, the it's just to think about hospital payment. If you look back 15 years ago, we had parity between commercial and Medicare insurance rates. And now commercial insurance rates for hospitals are 2.1x what they are for Medicare. Now, I would argue that Medicare is the one doing it right, and the excess hospital payments have simply led to rising wages for the top 5% of employees and a lot of granite lobbies. But, and hospitals are really, really nice in the US, many of them, like really nice. And I don't know how many you've walked into, but, they're pretty tricked out. So that's probably not a great use of money. But I can understand why the pharmaceutical industry would say, we've got to think 20 years in the future, and we don't like this system, but we're just going to insist that it's all about innovation and everyone should focus on insurance expansion, and which will bring us more revenue, and never, to your point, never say, okay, now it's time to get serious about our products actually reaching people. It just, because I think it's right. I think, policymakers will look at this spending and they'll say, well, we can take 2% from here. Like nothing will happen in the near term, and pay for other stuff we care about. And the policymakers may be right, actually, in terms of societal outcome being improved by things like that. But the industry will be worse off. And so I think they're not going to let the camel's nose or even exhaled breath in the tent.
Yeah, no, there's definitely a slippery slope argument being used constantly that, and that's why they love people like Martin Shkreli, because they can go, look, there's a bad guy over there and he's not us. But, I think I wrote an article in Stat 4 or 5 years ago about how Shkreli may be an asshole, but he wasn't doing anything different than most pharma companies.
No, you're 100% right. Well, I have a slide where I show how much excess revenue Amgen got off of, what's their anti-TNF? It's not infliximab. Is it infliximab? I think theirs is infliximab. Enbrel, right. Yeah. Over the 1 year that Shkreli raised the price of Daraprim, he was going to make $200 million from it or something in gross revenue excess. And Amgen made about $2.1 billion in price increases from Enbrel or something like that. So, Shkreli was the distillate of the industry, stripped of all of the trappings.
Exactly, yeah. And he even said that. No one listened, but that was what he was saying, was I'm just the extreme end of this. And no one, to your point earlier, no one agreed where on that spectrum is okay. Everyone just started saying, look, 10% is okay, right? They go, wait a minute, 10% on all drugs? This is...
anything above CPI that you can't document is due to input costs. And as you know, because of these margins, they make on the, the gross margins, which is part of the model, for input costs to drive price increases would be, very, very difficult. A 10% increase in input cost should lead to a 2% increase in gross price if it's just a pass through, right? So, and
absolutely.
It's, for a while, you've been doing this for a while also, but, in the 2000s, there was a pretty kind of widespread agreement amongst the oncology sector that annual costs of cancer drugs shouldn't ever exceed, let's say, $50,000-$60,000, right? So the whole industry kind of had secretly colluded on this or agreed to it casually.
Yeah.
And then somebody broke that, and that was the end of it.
Yeah, absolutely. Yeah, no, it's ripe for fixing, which is the good news. So let's keep going.
Exactly.
Yeah, fantastic.
All right.
Peter,
pleasure speaking with you.
Stay safe, and hopefully I'll see you in person at some point soon.
It can't be soon enough.
Yeah.
All right, take care. Although it'll involve one of us getting on a plane, which we will both resent. So, all right.